Thank you, Dr. Jayagayatri and Dayakar for organizing this wonderful meeting. And I must congratulate Dr. Venkatesh on his 12th consecutive uh, sessions, which has been a super hit for postgraduates especially. So congratulations to Dr. Venkatesh on that. And I'm terribly humbled to see Dr. Srinivasan here at this young age to be present with us. It is such an honor to have you here, sir. Thank you so much. Now, the topic that was given to me is definitely not what you're anticipating, but is more to showcase what Orbit offers for the postgraduates, because in a year or two, you will actually step out into the real world and will start wondering what to do. So, Orbit is, I would compare Orbit to a Tom Cruise movie versus the rest of ophthalmic surgery to documentary movies. Well, if you wish to be adventurous and exploratory, I think your choice should be towards Orbit. So this is a small piece of advice out of my experience over the past 25 years. Thank you for giving me this. So if you look at what an explanation means, it is around why and how a phenomenon takes place. But if you look at the exploration in its true sense, it is a broad understanding, identifying the patterns and raising some ideas out of it, and then postulating your own and exploring its probabilities and eventually making yourself useful. So you can just live or you can make others live. The choice is yours. You can either just live or make others live. I think most of our orbital surgeons who are here and those who are in this room, experienced senior members, are all making others live through this surgical field. So I wish to expand the horizons of the orbit. What are we actually dealing with? We're dealing with inflammations, infections, trauma, anomalies, and tumors. Now, to start off, in the early years, I did do a bit of an exploration. In the sense, I started understanding what were the cases that were coming to us. We did a review of for 5 years, we gathered about 6,000 and odd consecutive cases, and we evaluated the frequency of the orbital disorders and compared our experience with the previously reported series. And surprisingly, we were able to compare it with 5 published series, which were world-renowned. I'm sure all of you must have heard of Shields, who are a super classic couple who have done extensive work. They published in 1984. Kennedy, Henderson, Rootman, and Wilson. All of these are big names in orbit. And we could see that we could easily compare it. And surprisingly, their 20, 30-year series were easily surpassed by our series. Not to brag, but then our Indian numbers are far, far more than what the rest of the world offers. Which means if we are together, all of us together in this room, if we are together, we can easily surpass the entire world numbers. And what we came across was, we found out that there were at least 30% systemic conditions, which is often thyroid, other conditions. So we have systemic conditions manifesting in the orbit. We also have a lot of orbital inflammations. We have about 20% neoplasms and about close to 10% congenital lesions, and only a 5% contributing to trauma, which means we are not alone in this game. This is going to be a multidisciplinary approach, which is why I think we had the radiologist talk prior to my talk, and we are going to have the ENT surgeon. I'm sure if time had permitted, Jai Gayatri would have involved many more, the list of which I will tell you in the end of my talk. So what does oculoplasty actually involve? It's either cosmetic, and today the world is more towards cosmetic, but we all focus on functionality as the priority. Function comes before cosmesis. But cosmesis is not a crime. You know, people misunderstand it. We can add functionality with a lot of cosmesis. It's corrective surgery, it's reconstructive surgery of the lids, brows, orbit, and the tear ducts. Let's look at the video. I always feel that whenever I start giving an orbit talk, there's a lot of ptosis in the room. So now I want some bright, open eyes. At least engage yourself in eating the samosas, if not for my talk. So open your eyes and just watch this child. So she has a ptosis, unilateral ptosis, which can eventually lead on to amblyopia because there is no, the visual axis is not clear. Okay. So here it's a unilateral ptosis with a poor levator function, less than 4 millimeters, which means there is a poor LPS action, which means this child is going to have a surgery which involves a frontalis sling. The LPS action is completely lost. So we are doing a frontalis sling where I've made 3 incisions above the brow and I'm engaging a silicone material into each of these incision sites. There are 2 incisions just above the lid margin, and you can see that, excuse me, the needle is being threaded along with the silicone material, and that needle is being passed through each of these incision sites. This method is called the Fox pentagon, and it's very popular. So in your exams, this could be described very easily. And I've left this for you to understand that this is an important question. And the next thing is, you can often wonder, every surgery has moved towards sutureless. Now let's look at what we have in this frontalis sling. So this is a pre-op picture. This is a post-op. You can see pre-op, post-op. It's beautifully corrected, which means your visual axis is cleared. Now let's look at a technique where we don't have to use much of these incisions. So you just make one small incision, which is hardly about 2 millimeters, and you have to flip the lid and do a transconjunctival frontalis sling. So if there are, recently the questions are more towards recent advances. So this is one recent advance that has taken place in the frontalis sling procedure, where you flip the lid and you can make the sling. So basically, you're going to elevate the lid using the frontalis muscle, but I've just taken it for just one forehead. So you can see how it is elevated. Now, the question is it used in all cases? Ideally, it's used in scenarios where you have to clear the visual axis. Okay. So basically, so this is the pre-op picture you see here, and this is the post-op picture. You can see. Now you might wonder, this looks a little retracted. So what is this rule? The Herring's law is acting. So this is the ptotic lid. So when there is a ptosis on one eye, the other eye tends to have a retraction. That is the Herring's rule. So you correct the ptosis, this lid will automatically fall in its original position. So this is another exam question. Now the next important area is the blepharophimosis syndrome. Any syndrome involves more than one problem. So here you have a telecanthus. There is ptosis, and there is also horizontal shortening. So there is a vertical shortening, there is a horizontal shortening, there is telecanthus. In addition, there is epicanthus inversus, and sometimes there'll be an entropion or an ectropion of the medial or the lateral canthus. So The syndrome includes telecanthus, epicanthus inversus, ptosis, horizontal shortening of the lid with or without entropion and ectropion. This is about the blepharophimosis. So what is the corrective surgery for this? First you need to correct the epicanthus inversus where we do the VY plasty. The VY plasty for the epicanthus inversus, and to increase the horizontal aperture size, we do something called the lateral canthoplasty along with the VY plasty. So your horizontal length is increased, and then you do a ptosis correction by doing a frontalis sling procedure. The telecanthus can be corrected by a transnasal wiring. Earlier, we used to do in multiple stages. Now we do it all in one stage. Okay, so that is the corrective procedure for this blepharophimosis syndrome. Another interesting feature, I want somebody to tell me what it is. It's the Marcus gun jaw winking phenomenon, which is not easily elicitable. Patients come with a ptosis. The patient comes to you like this, and then you wonder what it is. If you miss doing this opening and closure of the mouth or sideways movement of the mouth, you're going to miss this phenomenon. This is because of the misdirection. So how do we do this corrective procedure? Now let's look at this video where ideally the flutter of the upper lid is because of the levator muscle. So you knock that levator muscle off. So you have to disinsert and actually excise a portion of the levator aponeurosis, because if you leave it alone, it'll just go and reattach. So disinsert the levator aponeurosis and excise a portion of the aponeurosis. In fact, you excise the total portion of the aponeurosis and you can do the frontalis sling. Once you have disinserted or dissected out the levator aponeurosis, you're going to lose the action of the levator, which is responsible for the opening of the upper lid. So once you've excised it, you've lost the function of the levator. So you have to use the frontalis sling in order to correct the ptosis. So that is the procedure that is being done, which I already showed you in the earlier video. But once it's done, it's not easy for us to stop there. So the lid, if you see, the contour is good, the lid height is good. We rest the lid on the upper limbus. Okay. So next, we have to check out whether this guy had this flutter earlier on before surgery, and this is post-surgery. Let's look at how he is functioning. Now he's opening and closing and his flutter has disappeared. All right. Now, I just recently saw the question paper, recent DNB question paper. It spoke about aponeurotic, the recent advances in aponeurotic ptosis. So what happens in aponeurotic ptosis? There is a disinsertion of the levator aponeurosis. And so there is a high lid crease. So absent lid crease in congenital ptosis, which is where you do the frontalis sling, and high lid crease in levator disinsertion, which is where you do this procedure. Here, most often when there is a levator disinsertion, there is an additional papery skin. So that manifests as blepharochalasis. Blepharochalasis usually comes in earlier part of life, which manifests as papery skin. And sometimes you will have a little bit of fat prolapse, which has to be carefully excised. What I'm holding and suturing is the levator aponeurosis. So you measure the amount of aponeurosis that you have to excise and reattach the rest of the levator aponeurosis. So now that's the lid contour and the lid height that you get. One in the center, one on either side of the central suture. Excise the excess levator aponeurosis. So the next question will be, how much of levator aponeurosis needs to be resected? For every millimeter of ptosis, you have to resect about 3 millimeters of levator aponeurosis. This is the standard algorithm that has been prescribed in literature, but you always have to compare it with the other eye. So this is the pre-op And this is the post-op. You can see the beautiful correction here. Now, again, for the recent advances, you have the modified adjustable suture where you dissect the levator aponeurosis. And this is a slightly complicated suture that we put. It's called it's just like the belt clip that you have, the paper clip that you have. So it's slightly complicated, but it's called the belt clip adjustable suture. So this is one of the recent advances that you can quote in your exams. You really need not go into it. This is more a higher version of it, but you can just see the immediate correction on the table. And if need be, you can adjust it later on. So this is the pre-op and the post-op picture. Now you can do, again, everybody fancies the single stitch. So you can actually measure the height at which you want to rest the crease and use local anesthetic, inject and expose the levator aponeurosis. Because in disinsertion, it usually rolls up and you can easily identify the levator aponeurosis, and you can just include the skin orbicularis and then the aponeurosis and attach it to the anterior surface of the tarsal plate and bring it out just the way you went in. And you can see the correction instantaneously on the table. This is more for the elderly population where you really don't worry too much about the lid contour and you don't want to do extensive surgery. Now, Dr. Loganathan sir spoke so well about external DCR. I just want you to see the gamut of DCRs that we can do. We can go external. I'm a little apprehensive to show our endonasal DCR, sir. You'll have to forgive us for this. But then we also do endonasal DCRs. And I'm sure Jay Gayatri and Dayakar are also doing it, but we may not like to show it to you. Our ENT surgeon friend has to excuse us for all the mistakes that we are making. Yeah, so we expose the bone and we try to expose the sac. We split open the sac and we actually pull out the sac. And we don't do too much of damage to the mucosa. We cut open the sac and remove a portion of the sac and open it up. And then we intubate it. And that's how it is. So we also have the laser procedure. I will tell you the comparison of the three, and then you can decide what you want to choose later in your life. So the laser actually was like at one point what femto is today. People were crazy about it because it's very quick and instantaneous results were produced. But what we saw as a big disadvantage, I'll talk to you in a moment. So that's the laser that we try to do. The laser shots are being made there. And there is an opening made instantaneously with all the burns there. And you can see that the fluid seeps out immediately. So then you can intubate it and the results are quite gratifying for that moment. Okay. So now with external DCR, which is the gold standard, we have about 95% success rates. With endoscopic DCR, in our hands, at least in my hands, the success was only about 80%. But with laser DCR, the success rate were as low as 50%. So the choice is yours. We also have the ocular prosthesis, which actually is a boon for all of us. Earlier on, if you remember, Aligarh was the only place where prosthesis was made in the entire country. So we could not afford sending all our patients to Aligarh. So we used to have stock eyes. But then we were very fortunate to have one American, Miss Dory, who came over to Aravind and provided us with the know-how of doing the prosthesis. And this is how the patient looks pre and post. Look at the pre and the post. It is almost near normal. You can do it in thumbsicle eyes as well. Just over the thumbsicle eye. You need not remove the eye. And look at the child with medulloepithelioma. You can hardly make out. And we also make the orbital prosthesis. Yeah, this was an eccentrated socket for which we fitted an orbital prosthesis as well. So this facility is also available now. Let's look at orbit. Now, this is how we started our journey in orbit. We used to, for a lacrimal gland tumor earlier on, about 20 years ago, we used to do the bone breaking surgery. We used to do an osteotomy. We used to remove the portion of the lateral orbital wall. And that's how we expose the tumor. And that's the lacrimal gland tumor you see is a pleomorphic adenoma. So that's how, and we reposition the bone using suture materials. You can fix it with plates and screws also, but this is an immobile portion, so it doesn't actually require any plates and screws. This was in 1947, I would say. No, just joking. It is 20 years ago. Now we have moved on to, now our radiologist sir had shown you the pictures of some hemangiomas. So the one rule is, so I would request all of you to understand what a coronal section is, what a sagittal section is, and what a axial section is. So you need to know these three sections first before we go in for any interpretation. All right. And in exams, you're not expected to know what sir knows, but you're expected to know these three in particular. So what section would this be? This is an axial section. So you slice your head like this. Sir, pardon me for being so crude, but this is how I can explain. This is axial. This is coronal. And you slice it like this is sagittal. We need all three views in order to understand and localize the tumor or the foreign body and get these sections done. So you have to request your radiologist. Okay. So I just wanted you to see how we have transitioned from bone breaking surgery to a simple transconjunctival approach. So earlier it was a lateral orbital approach. Now it's just a simple. And what was the tumor? I'll just show you the. So this is the proptosis. You see that proptosis. And this is how it looks post-operatively. And this is much later after a month. And all that size tumor, we could get it out through a transconjunctival approach. So now we have transitioned from a bone breaking surgery to a transconjunctival approach. So we used to have lateral orbital approach, the stellar right approach, which is the one which I showed you earlier, to a transconjunctival. Now let's look at other approaches. Here, this is a young woman. If you look at her closely, her elevation in the left eye is restricted. And I'm showing you the pictures. You see a superomedial lesion. And I'm using the skin crease approach. And I try to dissect out careful dissections, only blunt dissections. And you see a beautiful tumor coming out. So there are, if you closely observe, there are some yellowish nodules on the lesion. This turned out to be a schwannoma. Okay. So this is again another approach. So we had a lateral orbital approach. We had a medial approach. We had a superomedial skin crease approach. So basically, you're having different approaches to avoid any bones that is being excised. I'll tell you when the bone has to be broken. So this hardly leaves any scar for the patient. Now let's look at this 45-year-old male with an eccentric proptosis. You can see the proptosis here. You can see the lesion right behind the globe. So earlier we would have definitely gone for a lateral orbital bone breaking approach. But now we are able to easily get the tumor out through a transconjunctival approach. So this is again a lateral canthal approach, lateral transconjunctival canthal approach. Now, we need to also look at other conditions where we need to do a orbital approach. Here, this is an optic nerve sheath decompression, especially when there is papilledema, usually associated with raised intracranial hypertension, especially idiopathic. Okay, so this is a scenario where we had to just do an optic nerve sheath fenestration. So we are taking the medial approach. We actually identify the medial rectus, disinsert the medial rectus, and go towards the optic nerve sheath and decompress. You can see the egress of the CSF, and then you reattach the medial rectus through the medial approach. So it's again a medial transconjunctival approach. Okay. Now you see a woman with the elevation restriction. This is a post blowout fracture. Now what I do is a transconjunctival, inferior transconjunctival approach. This is the defect that I see. I create a template. I use a silicone sheet to cover the defect. You'll have to remove the contents from the sinus and then position the and suture the conjunctiva. So the implant is positioned through the transconjunctival approach. You release the inferior rectus and the fat that's prolapsing into the sinus, and then you cover the defect with an implant. Earlier, they used to go through the skin approach. Now we have shifted towards the conjunctival approach. Now I just want to show you that with a lateral canthal approach and a transconjunctival approach, a tumor of this size could also be removed. So here I'll show you how we did this. We just made a lateral canthal incision, and via the transconjunctival approach, we excise the entire tumor. It is quite a large tumor, but then we were able to easily take it out through the conjunctival approach. A little bit of effort. Yes. That's a big tumor, much bigger than the size of the eyeball. All along the surgery, you have to ensure that you're not compromising on the optic nerve. And a sudden decrease in orbital pressure also can cause a central retinal artery occlusion. So that also has to be borne in mind. So that's the size of the tumor, as you see. And it is excised. And the closure is done. So it's basically one small incision along the crease lines. This will easily hide in a crease line. Okay. So even such large tumors, we are able to excise through such small incisions. So it turned out to be a pleomorphic myoepithelial cells. Why I kept this slide for you is it's a very rare tumor, but all these tumors are coming into vogue now. What was once rare is becoming common today. So we need to have a very good histopathologist with us. And we cannot stop with just histopathology. We have to go in for immunohistochemistry as well. And that's going to be the future. Now, so there was one fad at one point of time that any orbital surgeon without a navigation unit is almost like an obsolete surgeon. But I did try the navigation unit. I did not buy it, but I had tried the navigation unit at one of the centers. We do have a navigation unit in Chennai, but what's really not compelling us to go towards navigation is it's not been very useful for us. In our hands, it has not been very useful. I think it's better with the neurosurgeons and not with orbital surgeons. But there are very many advocates of navigation unit. And this is also one advancement in your orbital surgeries. So the next important aspect is you cannot stop with histopathology and immunohistochemistry. You need to go further, and we had to at one point, after seeing that we had a lot of heritable diseases, we needed to go into molecular biology also. That's why we set up the genetic center. Now, with a little background on RB. RB is a heritable first, I think it's the first genetic cancer to be identified. Okay, one quiz question. Number two is it's in this cancer that Knudsen found out the two-hit hypothesis. So these two credits go for this particular retinoblastoma. And what was annoying and shocking for us was about 40% of our cases which came to us were heritable condition. So that's when we were propelled to take up this genetic studies. And I'll show you examples. This is a mother who had her right eye enucleated once when she was very young. She survived, and she had the first child with retinoblastoma bilateral. We had to enucleate one eye because it was advanced. And as she was getting treated, she was pregnant with the second child. So we knew that there is a genetic preponderance. So we did a genetic analysis, and we found the mutation in the mother and the first child to be the same. So we preempted that this next child is going to have the same mutation, likely to have the same mutation. So she was brought to us as early as 12 days. And she unfortunately had bilateral retinoblastoma, but fortunately we found it so early. So we went ahead with chemotherapy intravenous, and we salvaged not only the life of the child, but also the vision in both the eyes. So we did not actually enucleate the child. Second one was, this was a similar looking twins. Actually, if you look at it, one had a retinoblastoma frank, the other had a retinal scar. So you would always wonder, would you have to subject this child to repeated anesthesia? So what we did was, we did a genetic analysis, and we found out that one twin had a de novo germline mutation, which means that child's offspring will have a retinoblastoma, but the sibling did not have any mutation in the blood. That is the twin sibling. So they were non-identical twins. So look at the irony, huh? Twins, and one has retinoblastoma, and we all think of one dividing into two. I'm going to quickly wrap up. So the twin B was saved from multiple anesthesias. Now here, the child was brought to us at 36 months. A little later. Usually unilaterals come in later. So when it comes later, it's usually advanced group E, and there was germline mutation identified in blood. The teaching is heritable disease is often bilateral and non-heritable is unilateral. But here it's broken the rule. Here it is a unilateral, which is found to be having a mutation, which is a germline mutation, which means that particular proband is going to pass it on to the next generation as well. So blood should be sampled for all retinoblastomas. Here, group E, germline mutation identified, closely monitored. It came as unilateral first and became bilateral. And what we found out was, on analyzing the parents' blood, we found out the father was an unaffected carrier. So there is a high risk for the next sibling. So it was unilateral, and then the blood was found to be a germline mutation. Father and mother was screened. Father was unaffected carrier. There was no evidence of retinoblastoma. So there's a likely chance for the next sibling to be affected. So here, one eye was normal, left eye was enucleated. So this child comes, after understanding about genetics, she comes to us and asks whether I will have any issues with my offspring. So she got married, she got her child. She didn't have any mutation in the blood. Her child also was normal. So we are able to predict. This is another one. The child was 2 years when he was brought to us. And when the enucleation was done in one eye, the other eye we could salvage using intravitreal melphalan. Even in those days, we used to use intravitreal melphalan wash, and we salvaged one eye. And the child wanted to know whether he could pursue his higher studies. He didn't want to invest on himself if he was going to get a secondary cancer. But his blood showed no mutation, so he found out that he was not going to be affected at all. Now, we also went and did a bit of prenatal testing. We did amniocentesis in a family where Patient had RB. He actually presented very late at 6 years of age. Mother had retinoblastoma. So it was generations of retinoblastoma. And when his wife got pregnant, he wanted to know whether there was going to be, embryo was going to be affected. Unfortunately, on amniocentesis and mutational screening, we found out that the fetal embryo also had the same mutation. And we left it to the parents to decide on what to do. So all the relevant investigations, as Dr. Venkatesh was pointing out in the earlier introduction, we are providing it free for the patients who cannot afford. We do all kinds of lasers, cryo, TTT, wherever necessary, intravitreals, intra-arterial also, surgeries and reconstructions, prosthesis, ocular orbital. We have moved from excentrations to salvaging the sockets. We only enucleate now. Earlier on, we used to have a lot of excentrations in advanced cases. We also do rehabilitation. Low vision aids are also being provided for these patients at no cost whenever necessary. So we also do a lot of celebrations with the survivors to encourage, like they have the White-a-thon and others. We have a Survivors Day where we encourage all the survivors to come and exchange notes and encourage each other. And so we've been in 23, we've been able to provide about free service to about 1,466 adult and pediatric cases. So what I wanted to tell you was, alone you can walk fast probably, but if you want to walk long, I think you need to have a team with you. So this team of people, oculoplastic surgeon, ocular oncologist, radiologist, anesthetist, physician, pathologist, endocrinologist. Did I put the radiologist? Yes, I missed out the ENT. Yes, sir, you're also very much part of our team. And I'm sorry I missed that, but yes, you are a part of our team because orbit is one which contains a lot of tissues which are represented in the body. And orbit is one which gets metastasis from anywhere in the body and also encroaches on the neighbors. So I think we need a multidisciplinary approach. There's no doubt that we require a multidisciplinary approach. And I always would like to end by saying that one generation has done, at least our generation has witnessed less. That is, we were inadequate at a point of time. Then we became adequate. Now, I think you're living in an era of abundance. I think now the plate is actually full. You're only having a discomfort of having a full plate. You don't know what to eat. You're at that phase. Your plate is filled up with a lot of things. So it's up to you to take up focus on any area that you really are interested. And I'm not propagating or promoting orbit and oculoplasty, but I'm telling you, you will be blessed if you're going to be an orbital surgeon. And I just would like to end with hard work beats talent when talent does not work hard. Thank you very much.